Good afternoon. I'd like to welcome you to this talk on personalised care from Professor Alf Collins. I'd like to sort of briefly introduce Professor Collins, who's currently NHS England's Clinical Director for Personalised Care. He has a strong background in spinal care. He trained with Nicola Bogduck many years ago now, I think like you were saying. So he initially had a special interest in spines, and he's now expanded his practice into looking after the whole person attached to that spine. He is an expert in shared decision-making, self-management and social prescribing, and he holds those briefs at a national level. I'm hoping talk today we'll be able to learn a little bit more how we can put those principles into our daily practice. Alf Collins.
Thank you very much. Thank you for the invitation, Dermot. It's much welcomed. It's great to be here in Glasgow. It's the graveyard shift, isn't it? We'll have some beers very, very soon. I was just saying to Dermot, this is my third talk today. I've had 2 Teams talks from my hotel this morning. This is the one I've really been looking forward to, because actually working with people with spinal pain has been my bread and butter for many years. As Dermot said, I'm now full-time in NHS England. I often describe my career trajectory as going relentlessly downhill. There I am, National Clinical Director in NHS England. But for many years I was the director of the Somerset Community Pain Management Service with a very specific interest in supporting people living with chronic pain. I also have had a career working in think tanks. So I spent a decade working in the Health Foundation alongside my clinical role. And we spent 120 million quid across that time looking at person-centred, personalised care, primary research, applied research, but also really quite big national demonstration programmes to see how you could get this stuff really going in the real world. So I'm going to share some thoughts with you today about personalised care and very specifically about shared decision making. Well, I hear that this morning you've been told that we might want to think about it as informed or supported or facilitated decision making. I'm pretty cool with that. I still call it shared decision making, but I'm cool with other descriptors. So I'm going to talk about shared decision making, and I'm going to talk about support for self-management, and I'm going to talk a little bit about social prescribing. And I aim to finish very much on time so we can have an early beer. So what is personalised care? It's really whole person healthcare, just as Dermot said. It's about thinking about the whole person, not just the bit that hurts, not just the pain. It employs a biopsychosocial philosophy. George Engel described the biopsychosocial philosophy in 1977. I've still got the paper on my desktop. It's only 4 pages long. Do read it. It's really quite groundbreaking. We're still, I think, struggling to get to grips with the biopsychosocial philosophy really in our everyday practice, but that's what person-centred or whole person or personalised care is. And really the whole purpose of it is to enable people to become actively involved in managing their own health and care, engaged problem solvers and decision makers. We call it personalised care in NHS England because there were 2 groups of people in NHS England looking at the same stuff. One was the person-centred care team, looking at shared decision making, support for self-management, and the other was the personalisation team, which comes from a social care background. So we just lumped the 2 teams together. And we think it's actually symbolically quite an important thing that in a time of integration, we think about personalisation, a social care kind of concept, and person-centred care, more healthcare-related subject, as being the same thing, personalised care. We've described 6 core components playing out according to different contexts, and those components are shared decision-making, choice. Let's not get onto choice today. We can if you want, but frankly, I'm not a great believer in choice, although our current Prime Minister is. Supporting people to build knowledge, skills and confidence to manage their own health and well-being. Social prescribing, personalised care and support planning, and personal health budgets. Again, let's not get sidelined onto personal health budgets. It's for people that you don't see. So let's think about back pain. I understand you've also had a a talk about unconscious bias. What's the first thoughts that come to mind when you see that picture? Don't shout them out necessarily, but what are the first thoughts or feelings that come to mind? Maybe there's something like this: needs to see a physio, needs to see a pharmacist, needs to see a psychologist, needs to see a chiropractor. Hands up if you think needs to see a chiropractor. Maybe not. Needs to go to the gym, needs to see a spinal surgeon. What we all have is a series of biases in our head that kind of drive us at a very kind of limbic level when we work with patients. And what we look for in the papers that we read is essentially interpretation of new evidence as confirming our existing beliefs. That's why I told you about my story before I got into the depth of this talk, because I've got major biases as well. My biases come from the fact that I was a major interventionalist when it came to spinal pain. I audited my own practice, realised my results were crap, went off and learned motivational interviewing, and realised the reason I was doing so many interventions was I wasn't having a great conversation in the first place. So my whole career has been about enabling or encouraging or supporting our workforce to develop motivational interviewing skills. And MI skills are behind support for self-management and behind shared decision-making. So our practice is generally informed by habits, not necessarily evidence. And there's been some great work by a professor of general practice in Southampton called John Gabay, who's looked at this in detail and talks about so-called mind lines, not guidelines. In other words, although we'd like to think we were evidence-based practitioners, and some of us may well be in this room, what we tend to rely on when it comes to our clinical practice is in part evidence and guidance, but mostly what we learn from each other, what the reps tell us, what we talk about in coffee rooms, what key opinion leaders talk about, which is sometimes evidence-based and sometimes not. But also what patients are telling us. Oh, last time I did that, it seemed to work, and that's a self-reinforcing loop. And of course, we can fall into the trap of that self-reinforcing loop, because many people we see, and many people in this audience now, are the last link in the chain. We see patients who are desperate. We really do. And our limbic response is to do something to help. We've all got the helping gene. We all want to help people. And it can be really, really, really difficult to say to patients, I don't have a fix for you. But actually, that's our stock in trade, isn't it? When working with people with spinal pain, sometimes we've got some stuff that we can do that can move towards a rehabilitative approach, but often we don't have stuff that we can do in terms of interventions or pills. And whilst we're on this idea of patient expectations and mind lines and guidelines and evidence, Tammy Hoffman, who's a researcher in Sydney, is a close colleague of mine, and did a systematic review of patient expectations in JEMA in 2014. The systematic review is called Patient Expectations of Treatment Benefits and Harms, and what that systematic review really convincingly showed was that the majority of patients significantly overestimate treatment benefits and significantly underestimate treatment harms. That's not surprising, is it? We kind of know that. Part of our working life is managing patient expectations. What was really, really cool was that Tammy and her husband, he's died unfortunately since then, did a further systematic review 2 years later and just changed one word, clinician expectations of treatment benefits and harms, and showed exactly the same. The majority of clinicians significantly overestimate treatment benefits and significantly underestimate treatment harms. So, confirmation bias, mind lines, a lack of knowledge of treatment benefits and harms means that, to be quite honest, we're very often caught in a lie with our patients for all the right reasons. We want to help. We don't want to scare them. We don't want to worry them. that we as a profession, I'm not talking about you, I'm not talking about any particular person here, I'm talking about all of us, including me, get caught in the trap of overestimating treatment benefits and underestimating treatment harms. And this is where shared decision making comes in. It's evidence-based healthcare tailored to individuals. It's not just a nice to do. It's not just the soft and fluffy stuff. This is about the application of population-based evidence to individual circumstances. Highly, highly aligned to evidence-based practice, and I would say one of the core routes to evidence-based practice for everyday jobbing clinicians. What shared decision-making is a coming together of all relevant evidence. And if you look at decision theory, and it's my job to look at decision theory, decision theory says you should improve decision quality by drawing on all available information. And in healthcare, what that means is drawing on information that clinicians know and information that patients know. We know, or we should know, about the options, the evidence-based options. We should know about the benefits, the harms, the consequences, and the burdens involved. Also the uncertainties. And what patients know about are their circumstances, their values, and their preferences. And by preference, I mean a course of action that they would like to pursue, given their understanding of the options available. Why is this so important? It's so important, I hope you can see, because we're not very good at evidence-based practice. And evidence-based practice is about the best use of money, as well as the best treatment or support mechanism for the individual patient. So, if we do shared decision-making well, we come to the highest possible decision quality, the highest possible value for the individual, the highest possible value for the population. And if we do it across pathways of care, we can start to develop a high-value, sustainable health system. So it's not just the soft stuff, this. This is incredibly important, and I would say critical, mission critical for a sustainable NHS. And what can happen in that conversation is that patients move from an uninformed preference, I mean, this is a terribly simplistic uninformed preference, I want a hip replacement, to an informed preference. Now I know about my options, I think I'll go back to that walking group. I use this example because I've got a dodgy hip myself, and frankly, I'm staving off all thoughts of a hip replacement by keeping as fit as possible. Yeah, you might look at me and think, is he as fit as possible? Maybe not. I'm trying. So it's highly aligned to evidence-based practice. It's the methodical application of population-based evidence to individual clinical characteristics and personal preferences. And it was first articulated by David Sackett, who was one of the godfathers of evidence-based practice in 1996. Coming together of clinical expertise, best evidence, and patient characteristics. So patient preferences really, really matter. They really matter when it comes to decision quality and when it comes to improving the conversations we have with patients. And the cost of poor decision quality, if patients are unaware of the options and clinicians are unaware of patient preferences, is massive opportunity cost. We could be spending that money elsewhere. That is a waste of money. Burden or harm, patients might end up having operations that they didn't necessarily want, were they to have known that there were alternatives, and low adherence to a given course of action. It's part of good medical practice, which is about supporting patient autonomy, and there's the list of what the GMC says about shared decision making. Of course, in 2015, Nadine Montgomery, after 15 years of going through the courts, overturned tort law. You've heard about that this morning, the Montgomery ruling. I'm sure everybody in this room knows about the Montgomery ruling, but essentially, I'll talk about it as well in the next slide, it has shifted the responsibility for decision making onto patients. Patients are the primary decision makers now. I would say they always should have been, but in law, in tort law, patients are the primary decision makers. There are 7 principles in the decision-making and consent guidance. The second principle is that decision-making should be a process and not an event. And I'll talk more about this in the next couple of slides. This is a really significant shift, and I'm sure all of you know about it. For those who don't know about it, have a look at the consent guidance. But you know, the fact is, although we'd like to think we're good at shared decision-making, remember I've already said to you, we're not great at understanding benefits and harms of treatments. Even if we do understand the benefits and the harms, we're not very good at communicating the benefits and the harms. There's a paper there in the BMJ by Alex Freeman demonstrating that rather beautifully. And actually, we rarely seek patient preferences. In the best results in the literature, it's only happening about a quarter of the time. We rarely say to patients, what's important to you when we go through your options? About a quarter of the time. And that final quote on there from Chris Dowrick was an ethnographic study, just sitting in on consultations. And what Chris noted, is Professor of General Practice in Liverpool, was that patient involvement in decision-making is often confined to them objecting to courses of action proposed by clinicians. So we've a way to go in all this. I'm not criticising you, I'm stating what the evidence says. We've a way to go. We probably only elicit patient preferences, what's important to them, in about a quarter of consultations. And frankly, when it comes to the ethics, we're not doing as well as we should. And when it comes to the medical legal situation, we're absolutely not doing as well as we should. Because this is of a particular importance when it comes to materiality. Materiality in terms of consent is significant impact on the individual should a known risk materialise. And in the Montgomery ruling from 2015, Lords Kerr and Reid said the test of materiality is whether in the circumstances of a particular case, a reasonable person in a patient's position would be likely to attach significance to the risk. Or, so there are 2 provisos, the doctor is or should reasonably be aware that the particular patient will be likely to attach significance to it. In other words, it is down to clinicians to elicit patient preferences whilst talking about options, benefits and harms. So how the hell do we do this then? How the hell do we do it? First off, what I would say is, if we do this well, it does not take more time. I've trained people in shared decision making for the last 20 years. It does not take more time. And actually, it improves job satisfaction for clinical teams. Decision counselling is important, having the skills to counsel people about the options. And decision support tools, I think, can be particularly relevant when we have known evidence about benefits and harms. And implementation means making sure patients are prepared. I'm not going to go into this in enormous detail, but you can have the slides afterwards. There's a whole heap of ways of making sure patients are prepared. If you say to a patient in a consultation, what's important to you, and they're not prepared, they look at you, I've tried it, right? I've tried it. They look at you as if you're mad. Whereas actually, if they've been prepared to articulate what matters to them beforehand, you can have a really good conversation about their preferences. So that's the left-hand side. The right-hand side, it's really important that we're trained in motivation interviewing and communication training. Look at the Personalised Care Institute. We set it up 4 years ago. It's got masses of e-learning, the latest of which takes 10 minutes. So do have a look at it to look at some tips around motivation interviewing. And we need to make sure the system is supportive and we've got decision support tools in place. I'm just going to go through what this kind of shared decision-making conversation looks like. There is an internationally respected heuristic, the 3 or 4 talk model. Step 1 assumes a diagnosis has been made and is very simple. It's about rapport building. Hello, my name is, it's good to meet you, I am, being clear about our role. As I understand it, we're here to talk about the best management of your back pain and to decide together what the best course of action is. Is that your understanding? Simple, straightforward rapport building. I'm sure you always do it. The next piece, and this is where we don't do it as well as possible, have you had a chance to think about what you'd like us to focus on today? So handing over the control of the agenda to the patient. Feels really scary when you first start doing it, but if you get this patient preparation bit right, they'll start talking about the sorts of things you want to talk about yourself. What would you like us to focus on today? So it sounds as though you want to know about all of the available options, is that right? Now, if you send them a decision support tool beforehand, or they look at one in the waiting room, or one pops up on their video screen before you have the virtual appointment, they'll have looked through the decision support tool and be ready to have this conversation. Compile a list. What else? Is there anything else you'd like to discuss today? And then your agenda, if they haven't already covered it. We're going to talk about A and B. I wonder if we could also talk about C. But as I say, that's rare if patients have seen a decision support tool beforehand. Goal talk. Have you had a chance to think about what you'd like to achieve as a result of treating your... By the way, I wouldn't expect you to just run through this list as a kind of a didactic do it like this. These are just some ideas. Just some ideas. And what I want you to do is have a look at them, have a think about them, and perhaps go away and you're almost certainly doing quite a lot of these anyway, but try one or two in your everyday practice. What do you want to achieve as a result of treating your... What are the activities that are most important to you? What matters most to you? Tell me more about what's important to you. Tell me more about yourself and how you'd like life to be different. A whole heap of curious prompts for people to dig into themselves and start to think about what they want from the management of their back pain. And then option talk. Reinforced partnership. We have a number of options to consider, and we don't have to do anything. Introduce the decision support tool. In training, if it's a face-to-face conversation, what we often do is invite clinicians to hand over the decision support tool. It's kind of handing over power, handing over information, handing over power to patients. This is yours to keep. It tells you about your choices. Why don't we think it through together? They should already have seen it. There's no right choice from my perspective. As far as I'm concerned, only what's right for you. Then link it to the goals. Hold in mind what's important to you as we think through the options together. What do you already know about your options? Why don't we look at those pros and cons? And tell me your thoughts as we think through those options. An invitation for people to express their goals and preferences. The idea being that people move from a prior preference, I really want a hip replacement, to an informed preference. Blimey, now I know about the options, the benefits and the harms. I think I'll go back to getting as fit as I can possibly be. That's a brief run through. Do look at the Personalised Care Institute. We've trained tens of thousands of people in shared decision making. On the right-hand side is a virtual patient. We launched it today. We don't have a back pain virtual patient, but we have got a knee and hip pain virtual patient, same stuff. It takes 7 to 10 minutes to go through it. It's free registration on the website. It's been done alongside Keele University and the MSK team there. And it's a huge amount of fun. If you're tempted to look at other stuff, there's also half an hour of e-learning on shared decision making at the Personalised Care Institute. And there's a whole heap of much deeper stuff about risk communication that we co-developed with the Winton Centre. Have a look at it. Give it a go. I'm going to be honest, I've been a communication skills trainer for about 25 years now. And when I first tried one of these avatars, I thought, it's going to be, I can do this. And I learned a lot. It's really quite cool. I'm going to go on and tell you about our decision support tools, but just as an example of what decision support tools look like, they improve decision quality, they reduce litigation, they improve satisfaction and engagement, all that stuff, and they help align our practice to GMC guidance. So we kind of think it's quite good if people use these. We don't yet have any, and currently we don't have any planned for back pain, but if you want to come and see me and lobby and petition me to get some for back pain after today's talk, then maybe we can talk. We're actually looking at very, very high volume surgical specialities at the moment. They look like this. This is a cataract tool. On the left-hand side, it makes it clear what cataracts are. So for people with back pain, it would be really clear what back pain is. And then it tells people their options. Most patients don't even know there are options when it comes to clinical treatments. Then it tells you more about the options on the right-hand side. And this is what we want patients to look at before they come to clinic. On the left-hand side there, number 3, is an explicit what matters to you, so that patients talk about or start to think about their preferences, and they write down their preferences on the decision support tool. So knowing about your preferences, being prompted to know about your preferences, will help you working with your clinician to improve decision quality. The first 3 pages are for patients to look at beforehand. That page on the right is to use in clinic. Remember I said that the evidence is that clinicians, A, don't know as much as we'd like to think about the benefits and harms of the options available, and B, we're particularly poor at communicating them. We work with the Winton Centre for Risk Communication, kind of world experts in doing this, to develop this tool so that we can use it in the clinic and patients can do it beforehand as well. My wife, she's got 4 degrees, and she's also got a cataract. I'd been told by an optician she needed an operation. She looked through this decision support tool. She'd not been told about any of the other options at all. And I was the same. I just thought, oh, blimey, cataract, yeah, get an operation. And then we looked at the decision support tool together, and she'd not done any of the stuff in there that can improve your cataract, stop deterioration in your cataracts. Strange, eh? What I do want to say is that the menu of options, what's on the option list, should be defined by the evidence base. But what I want to say, and again, medically, legally, as well as ethically, there is no obligation to provide a particular patient with a specific treatment as long as the decision not to offer the treatment is ethically justifiable. And that could be because there's no clinical indication. You know, there's no real point to giving somebody a knee arthroplasty if they haven't got arthritis. There's no evidence. It's not in the patient's best interest. That needs a bit more teasing out from an ethical perspective. It's futile or it's too expensive. NICE tells us about too expensive. So we don't have to do stuff to patients because the evidence base tells us it's possible. I do want to really reinforce this. And one of the skills of shared decision making is saying no, actually. It's not just giving responsibility to patients and saying, well, do what you want. It really, really isn't. I want to just touch on 2-stage decision making, and then I'm going to spend 5 minutes looking at self-management support, and then we can have questions. You may know about Ian Paterson. He's been on the news just last weekend. He's in jail. He was a breast surgeon. I'm going to use this next word advisedly. He mutilated many tens of women doing non-evidence-based surgery, and it's looking now as though many tens or possibly hundreds of women have died due to poorly treated cancer under Ian Paterson. I was one of the NHS England respondents in the Paterson Inquiry, and we had testimony from patients at the beginning of each of the sessions. God, it's funny, isn't it? It's actually making me well up now. It was bloody heartbreaking. It was absolutely bloody heartbreaking. People submitting to non-evidence-based procedures when they hadn't shared a decision and they hadn't had a chance to think about it. So we've now come up with this idea of so-called 2-stage decision-making. Consent is not shared decision-making. Consent is informed by the principles of shared decision-making, but shared decision-making is an unbiased discussion about all reasonable options. Consent is a more focused discussion about the option that's been chosen, with a further, perhaps more in-depth conversation about the benefits and harms of the alternatives. So it should be a process, and what we're doing in NHS England is thinking about that process as being 2 separate conversations. Guidance from GIRFT is coming. Tim Briggs and John Machin, who leads in GIRFT on consent, and I are going to be leading a small working party. We're going to make sure it's practical and sensible and doable stuff that we come out with, but I just want you to know about it. I understand the lawyers are already looking at this. So look, 5 minutes on self-management and self-management support. I've really majored on shared decision-making, but just to give you a few thoughts about self-management and self-management support, because of course it's the mainstay treatment strategy for people who live with low back pain. I started looking at some of the literature again, having not really looked at the literature that much for a few years. We were talking about back pain beliefs. Blimey, I started running a back pain clinic in 1993. We were talking a lot about back pain beliefs then. Gordon Waddell and Chris Mayne were talking an awful lot about it. We started thinking about fear and avoidance in the early 2000s, late 1990s, early 2000s. You know, it's still a core model. There was a systematic review in the European Journal of Pain in 2019. What it's about is that the way we understand or make sense of our condition or our pain influences our behaviours. It really draws on Howard Levinthal's illness representational, so-called common sense models, psychological models that have been around for 40, 50 years. I just wanted to share with you some ideas from the kind of health coaching field about helping people reframe their beliefs. So establish their current understanding. What have you been told is the cause for your pain? What do you worry might be the cause for your pain? Normalise. Normalisation is a great tool. It's one of the first steps in CBT. If they're incorrect, you know, it's tempting to say, no, that's not right. It's this. Normalise it. Many people I see have been told something similar. It's natural to think that severe pain must mean there's something really wrong. Normalise, normalise, normalise. Why would you not believe that if you've been told by a surgeon? Not as though surgeons say that. Reinforce the experience is real. Many people I see tell me that sometimes they don't feel believed or their pain's somehow not real. Checking body language as you're saying that. You have real pain. Ask before advise. I wonder, could I share with you another way of thinking about this? Ask before advice is so important. And if they say no, that's fine. Explaining the limits of current diagnostics. Scan tell us that what your body looks like when you're lying down is a particular moment in time. And explain our current understanding of back pain. You'll have your own way of doing that. I'm sure it'll draw on models to do with the way our muscles work and the way our nervous system carries pain messages and the way our brain interprets pain messages. So I'm not going to go into that in detail, though I could. And explain why chronic pain is different to everyday pain. So your pain is real. You have real pain. It's different to the pain of a sprained ankle or a broken arm. And that's why medicines don't work. And that's why it's really difficult sometimes to actually reduce or relieve your pain and people like you. These are ways in which we can support people to start to think about improving function and managing the psychosocial impact of their pain. So self-management is a real option. It's about supporting people to set goals and develop action plans. But this is a team-based activity, right? I don't think consultant orthopaedic surgeons should be supporting people to develop goals and action plans. This is about teams. And if you're really interested in supporting self-management in detail, do look at the Realising the Value work. Google it. Google Realising the Value. We used it internally. We commissioned it internally. And it was done for us by Nesta and the Health Foundation. And we used it internally to support our bid for social prescribing link workers and health coaches. There is a taxonomy of interventions that can support self-management. I'm not going to go into them in detail here. If you want to really do this well in your service, then you need to have this infrastructure, this ecosystem around you, including health coaches, social prescribing link workers, peer support groups, group self-management programs, and group coaching programs. I'm not going to go into goal talk in great detail. You do have the slides, other than to say that we tend now to have moved away from clinical goals towards functional goals, but actually values-driven goals are what really help drive behaviour change. So talking about the way life is and the way people want life to be in terms of what's really important to them in terms of their values can help really motivate change. And it is real change. This is a slide from, I guess it comes from Seneca. This is about Stoicism. What I used to see when I worked in the pain clinic was people in the left-hand red box at the bottom in pain, wanting desperately to be the person they were beforehand, me not in pain. Why would you not? Why would you not want that? So desperately searching for someone to fix them, and or continuing to do stuff to the best of their ability and hitting the pain wall and then dissolving in frustration, anger, despair, and sometimes just giving up. So what supporting people to drive towards goals is about a new me. It's about a new identity. And it is tough stuff. It's really tough stuff. It's not straightforward. And it's why we need a team around us, including people who know how to do this stuff well. I'm going to give you some slides to take away on what goal talk looks like. But I just want you to take away from the bottom of this slide that setting goals and develop action plans is paradoxically not necessarily about achieving goals, but about learning and adapting. Only 11% of people start hitting their goals when they first start goal setting. And what I usually used to say to them in clinic, what this is about is not actually getting there, it's about the journey itself. But it's their goals and it's their action plan. Again, the takeaway from this slide is it's difficult to argue with your own plan. It's tempting as a healthcare professional to say, I think you should do a bit of this, I think you should do a bit of that. Why don't you do this? Why don't you do that? Supporting people to develop their own goals and their own action plan, it works. It's difficult to argue with your own plan. I've put down some skills there. Have a look at the slides if you want to afterwards. So I think what I hope I've impressed upon you is that personalised care is highly, highly aligned to evidence-based practice. It's not just the soft stuff. It really isn't just the soft stuff. It's ethically the right thing to do. It's medico-legally the right thing to do. And the evidence is pretty clear. When we do it well, it makes our jobs easier. Thank you for your time.
Thank you, Professor. We have 7 minutes for questions. If you just want to come up to the microphones. I have an initial one to start with. Obviously, we've had some breathing time over the last few days to reflect and replenish. When we get back to clinic next week, or some of us Friday, what should be our first steps to improve that personalised care that you mentioned?
Yeah, it's a great question, Dermot. In training, what I often encourage people to do is think about what comes into their head when they've read patient notes and they're just about to see them. What comes into your head? Quite often, what comes into our heads, because we're problem solvers, is a plan. We're going to do A, B, C, D, and E, right? In order to do this stuff really well, the plan should be, I'm going to share decisions with the next patient. So that limbic responsive, we need to do A, B, C, and D, which is what we've been trained to do. We need to start working on, A, recognising that, and start to think, well, maybe there's another way of doing this, and gently over time replacing it with, we're going to share a decision today. And actually, interestingly, it may be they come to a decision that I don't necessarily agree with. So step one is recognise your own inherent biases, particularly when you just read a patient's notes. Thanks, Dermot.
Excellent talk. Kaushik Ghosh from Preston. Sometimes in clinic you talk about options, risk, complications, and you try to get a shared decision, especially coming out of patient. But quite a lot of time the patient comes back and say, you are the expert.
Yeah.
What should I do? You tell
Right.
me. I will go with that. So how should we
Yeah,
tackle that?
yeah. It's a great question. I have to say, I've been talking about shared decision making for 20 odd years, and every time I talk about shared decision making, people ask that. Again, in training, what we tend to do is to offer people well, actually in training, what I would do if I came and trained your team was to invite your team to come up with words or phrases that they might want to adopt in order to encourage patients to become a decision maker. And what people most of the time come up with is responses like, well, I'm not you, and I'm not confident I know enough about you for me to make the right decision for you. So I just wonder if together we can look through these options, and as we're doing that, you tell me what comes to mind for you as we look through the options together. So there's a whole heap of words and phrases that you can use that are kind of like that. What I would say is that we shouldn't be pushing patients too hard. It is a reasonable option. You know, having been gently challenged once or perhaps twice in the way that I've just described, for patients to say, actually, do you know what? I really don't feel confident in this decision. What do you think I should do? For us to then say, so I think what you're asking is for me to make the decision for you. So my sense is that because of A, B, C, and D, it might be that course of action A is the right one. Really important, though, when we've done that we document it really, really well. Because lawyers, if there were a lawyer in the audience, they might just gently push back against it. It's a great question. Thank you.
Thank you.
Thank you so much. Very nice talk. Very stimulating and gives an insight, forces to think differently. But just
Could you speak up a little, please?
Sure.
I can't
Can you
hear.
hear me now?
Sorry. I'm
Can you hear
getting
me?
old.
Can you hear me now?
Yes, I can. Yeah.
Aprajit Gulash from Preston. I was saying is lovely talk. Give us an insight to think about things slightly differently. But just a comment about what you said. When you see a patient, you're about to see a patient, and you're preparing, and you're saying you've got a few plans in your head before you call them. I find that actually sometimes causes bias because you are reading the letter and you're creating image, and when somebody walks in, you get, oh, no, this looks different. So what's your comment about that?
So I think I am going deaf, actually. I think what you were saying was that it's reasonable in clinic, whilst you're looking through a patient's notes, to start to bring to mind the options that are available. Is that what you were?
Yes, so you were suggesting that you have the plans,
Yeah.
and then when you come in, you start to think about how you're going to share the discussion.
Yeah.
The thing what I'm saying is, at times, those reading the notes before the patient has come in,
Yeah.
give you a different bias. Because, then when they walk in and you say, okay, how do you protect yourself from that?
Yeah, so remember, improving decision quality means bringing to bear all relevant information. Part of that information will come from the notes, but part of that information will come from a really fresh conversation with the patient. And sometimes, as you know, the notes don't necessarily tell you what patients have necessarily said in the first place. So all relevant information, and reading to be honest, this sounds terrible, doesn't it? I used to rely so much more on the conversation than on the notes. Don't rip me apart for saying that, but that was my own bias, right?
Thank you.
Time for one last question.
Arshad Dabke from Salisbury. Can you hear me?
If you could speak more loudly, it is my ears, I'm sorry.
Thank you for an excellent talk. My question is about doing this in the clinic. I mean, like all my colleagues, we are fully engaged with this concept. But in real life, we get 20 minutes per new patient, and in the best case, 15 minutes per follow-up. In that 15 minutes, I need to take a history, examine, go through the scans, talk to the patient, order investigations, dictate my letter. How do I do all this? I mean, there seem to be two parallel lines that are not meeting. How do we address that issue?
So, I'm really sorry. I think what you said is that you're engaged in the idea, in the concept, Was it a question about
It's about time constraint in the clinic.
Yeah. Listen, the evidence is really clear on this, and there's been a lot of work done on this. And as I say, we ran a program called Magic in the Health Foundation for 4 years. We looked at questions of time. If patients, it's a matter of different people in the clinic doing different things. If patients are indeed prepared, and actually if, for instance, the receptionists in the clinic say to patients, have you had a chance to look at the decision support tool? Or if not, why don't you have a look at one now? Why don't you come and tell me what your thoughts are beforehand? So receptionists have got an awful lot of work that can be done there. If we change the way we organise our clinics, it does not take more time. It does not take more time.
I'd just like to thank Professor Collins for an excellent talk.
Thank you very much, everyone.